Pre-existing immunity to AAV is a huge issue potentially in gene therapy, because we sort of from first principles would expect that if you've got pre-existing immunity, you might effectively neutralise the AAV gene therapy drug that you're actually giving. And we know that AAV is really common in the population. So understanding the distribution of AAV serotype and positivity is going to be really important in terms of determining eligibility. The abstracts at the meeting are very interesting in that they look at a number of different serotypes, and one of the programs has shown really quite high levels of seropositivity to various serotypes and cross-positivity within those groups as well, and there appears to be some geographical variation within how these play out. So this is going to be so important to how we can use gene therapy in the longer term, because we may find that some AAV serotypes are just way more prevalent in some parts of the world. It's not a fully answered question yet at the moment about how relevant it is, but the basic theories stands that if you've got antibodies or neutralizing impact of antibodies, you would reasonably expect it not to work and to have a significant impact on the AAV that you administer. But as I say, there are some questions about that at the moment which are far from clear. So I think all this information is really valuable to greater understanding. The second question that you asked was, what can we do about this? Can we mitigate against it? Well, there's some data that's been presented at the meeting about potentially trying to remove antibodies. That could be quite cumbersome and quite involved. But if we are going to have to think about addressing the seropositivity and or re-administration in the future, these are clearly got to be approaches that need to be explored. And all this type of basic information that we're getting through is going to be really important to seeing whether this is actually feasible in the long term and whether it would be a practicable option.
We were looking forward to some of that data coming through, particularly relating to immunity against AAV. It is important for two reasons. One is, as we know, AAV is the most commonly used vector in the gene therapy in our disease area, hemophilia. It does have an implication if you've got pre-existing antibodies, in that you'll not be able to be infused with the vector in which the antibodies already pre-exist. But obviously it does also affect the ultimate expression of the factor that you want to introduce through gene therapy. What we're seeing is accidental findings that some of the patients that were thought to be AAV negative at the time of infusion, at least in one or two studies, would appear with better testing to have had pre-existing antibodies. So there is now planned studies to specifically look at patients with pre-existing antibodies to infuse them with AAV and see what the outcome is. It would seem, at least from the preliminary data that we've got, that some of those patients' presence of antibodies did not change the expression, which is important. So that is the one sort of coincidental approach. The other approach, which I think people are looking at very carefully, is to introduce immunosuppression. In other words, for those with low titer, and certainly those whose titer is not too high, one would then start off with immunosuppression followed by the transgene infusion. And it is thought that approach may well dampen the immune system, at least the antibodies against the pre-existing antibodies. But what is actually exciting with AAV is the diversity of the serotypes that we have. So the presence of antibodies against one serotype may well allow the infusion of a different serotype. And what is presented in this particular meeting is a number of abstracts relating to antibodies against a variety of serotypes. Perhaps the summary of that would be that overall it would seem it varies according to regions. Our own abstracts here seem to indicate that if you're looking at serotypes 1, 2, 5, 6, and 8, the seroprevalence, at least in our part of the world, is very high as 50%. The other studies that were done in the context of Europe and North America, it would seem that we're also looking at highish prevalence of about 32 to 40%, but not as high as what we found in at least in hemophilia B in our population.